I should not repeat these pages. And this is my first case, and case summary was already shown. So, right side angiogram showing there is occlusive ISR in RCA. Due to time constraint, I will go a bit faster. And on the left side, there is CTO in the distal LCX with probable channel inside it. And this is after 4 years after the failed attempt to the CTO in LCX. And retrograde filling of the RCA has been shown. I go with GR6 with pilot 150 wire first in the RCA. But it failed, and I finally switched the catheter and subsequently the route also. By the help of microcatheter, I finally can negotiate the wire up to the distal RCA. And sequentially, I predilate the lesion with 1.5, 2, and finally 3 into 12. And this is the view after predilatation. I took 3.5 into 38 millimeter days. And stent deployment is going on. And post-dilatation done with 3.5 into 8 millimeter end-systemic balloon. And this is the final angiographic view. On the left, at first I tried with pilot 150 once again with the EVU6 French catheter, but I failed. After several attempts, I took the concrete screw wire with help of microcatheter. And then I exchanged the wire with run through, predilate sequentially with 1.5 and then 2. Then I took this 2.5 into 28 millimeter. Due to time constraint, I'm not trying much more. And this is my second case. This is also 55 years old, but this time this is the lady patient. And she is diabetic for last 15 years, hypertensive for last 10 years. Due to time constraint, I am switching these pages. And she was on optimal medical management for last 6 months. And she was ETT positive 6 months earlier. And her pain was not controlled with optimal medical management in spite of 3 anti-anginal drugs. I went through cardiac cath, and there is 70 to 80% lesion in the RCA that seems to be non-dominant, and LCX seems to be dominant. There is also an intermediate lesion in the distal LED. According to ESC guideline, 40 to 90% lesions are intermediate in category. And so this is definitely an intermediate lesion, as the patient was symptomatic in spite of 3 anti-anginal drugs. So we decided to stent. At first RCA, we took GR5 French catheter with run-through floppy wire, titillation done with 2 into 12 pre-balloon, and 2.75 into 23 days deployed, and post-balloon done with 3 into 8 millimeter. And on the left, this is much easier than the left one. And we deploy stent directly without pre-balloon. After post-balloon was going on, whenever I remove the post-balloon catheter, then the patient suddenly developed pulseless electrical activity. And we do a check that showed the LED is totally occluded from the proximal part. CPR was going on instantly, and pulseless electrical activity was culminating into the BF, BT, and 3 shock was given. We instantly took another stent, 3 into 38, and deployed in the proximal to mid LED. And this is the final result. This is the easiest case I've ever done, but I faced the deadliest complications with the simplest case. So my take-home message is a hard case can be done smoothly, safely, and a simple case can end up with any disaster. Every interventionist should be prepared for any complications at any time of their procedure, should have adequate preparation for that, and no procedure is 100% safe. Thank you for your patient sharing.
Thank you, Dr. Atikur Rahman. Now for some questions, sir.